Good afternoon and welcome to Bariatric Friday. Today we will be focusing on the day of bariatric surgery. Bariatric surgery represents a remarkable milestone in the lives of individuals seeking to overcome the challenges of morbid obesity. As we embark on this journey, it's important to acknowledge the courage and the determination of those who have chosen to undergo the bariatric surgery. The decision reflects a profound commitment to reclaiming their health and embracing brighter, more fulfilling future. Throughout our discussions, we will delve into various facets of day of bariatric surgery, from the preoperative preparation to the post-operative care and ongoing journey towards long-term success. So with that, I have Dr. Irgau joining me. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Doing well. Thank you.
Dr. Irgau, with your screen, do we have, are you like maybe, is it too far out, the green screen?
So I'm going to bring the camera a little bit closer.
No, the screen actually needs to
Oh,
be.
the screen. Okay, so let me just adjust that. Give me one second. I'm going to take my picture out for a second.
So we'll wait for you. So while we are waiting, today is the discussion, as I mentioned in our in the beginning. It's going to be the day of bariatric surgery. So we will be preparing those who are ready to go. In many cases, we can actually see a lot of patients who may not be able to go through the whole process, but those who are actually able to finish their process, they are ready for this day. So Dr. Irgau is going to help me with the discussion. So we'll start with the preparation of the process. So Dr. Irgau, those patients who are ready to go, I want them to watch this, and then I want to be able to address many of their questions. So how would you start with this?
Okay, absolutely. This is the day, right? The day of surgery, very, very important day, a milestone, as you mentioned, for patients who have been obviously looking forward to this for a very long time. Looking forward in the sense that they know it's a way for them to liberate themselves from the ravages of morbid obesity, but also it's a day of having surgery. So some apprehension alongside that is also very common. In fact, patients tell me very often they're excited and apprehensive at the same time. And my answer to that is really the right combination of emotions when, expecting the surgery day. And as we have said in many of our sessions before, the process really to get to that day is fairly extensive, as the patients have to go through evaluation that includes, visits with nutritionists, with psychologists, with other medical specialists, including possibly cardiology and others. And they will have done many medical tests as well. And that is really to optimize their situation for the surgery. So the day of surgery really for the patients starts really in the middle of the night of that day. So at midnight of the day of surgery, patients have to do certain important preparation. One of them is that they cannot have anything to eat or drink after midnight of that day. Right, so that's an instruction that they will have from their surgeon, from the bariatric center. There is an exception to that, however, and the exception is they are able to take medications that are necessary for them with a sip of water, right? And that is acceptable. Now, this is actually important as well, because there may be some medications that are critical for them to continue taking. This could be medications for high blood pressure, for instance. They could be medications for anxiety or other mental health issues. But there may also be medications that they have to stop taking on the day of surgery. All those are obviously very individual situations that will have to be thoroughly discussed with their surgeon before their surgery. So if they have medications that they have been instructed to take, they should take them with a sip of water. On top of these medications that patients may have, there are actually some medications that the bariatric center will instruct patients to take before they come to the bariatric center on that morning. You are going to ask something, Kemal?
So now we said no food, no drink. except with the medication. Now, are there certain medications that we want them to avoid, though?
Of course, of course. So, for instance, if a patient has type 2 diabetes and they take, let's say, metformin, that would be a medication we would not want them to take, because if they do, then their blood sugar could be driven too far down at the time of anesthesia, and the anesthesiologist obviously would not like that.
Okay.
But as I said, these are individual situations, and it is important that at their surgical clearance visit that they discuss with their surgeon which medication is to hold off and which medication is they should be taking. Our medical record will have a list of their medications, so we know what medication they're on, and we will tell them, but it's important for them to really have that clarified in their head. Okay. Now, as I said, there are certain medication the bariatric center actually will or may ask the patients to take. For instance, we like our patients to take Tylenol extra strength before they come to our surgery center. Now, people may find this puzzling to why would I want to take Tylenol? Well, one of the things we do in our surgery center really is to prepare the patients for a comfortable recovery. Not necessarily pain-less recovery, but a recovery where pain is really very well controlled. And one of the things we do is actually provide pain medication ahead of the surgery itself in order to really prepare them to have less discomfort. And it has been proven if you give patients Tylenol before the surgery, actually you are able to mitigate the amount of discomfort that they will have after the surgery. So if they are instructed to do that, obviously they need to take the Tylenol extra strength at home, perhaps about an hour or so before they come to the surgery center, again, with a sip of water. All right? Tylenol extra strength. It's very important they clarify this as well, because sometimes people think Tylenol pain medication is similar to Motrin, it's similar to ibuprofen. These are very different medications that have very different effects. So it's important for them to be very clear in my mind about the instructions that they are getting.
And our nurses are calling the patients for pre-admission checklists, so then we would go through all those one by one, but we still want them to kind of have a general idea about certain things, do's and don'ts of the day before. In many cases, we see it in some other procedures like the colonoscopy and AGD. Like there's this pretty strict things that we shouldn't be doing. And then because of the poor prep, we end up rescheduling those cases, which is a problem. So, and we don't want to have we don't want to actually reschedule any of those cases for these simple mistakes. And the other thing is, as you mentioned earlier with Tylenol, they should have the best experience. Pain doesn't mean that it's they're going, they have to just deal with the pain. That doesn't have to be. So if we can prep them for the proper, for better preparation, so that they can actually proactively deal with certain things, then things are going to be better. Now, I'm going to kind of just ask some of the questions from the patient's perspective, very simple, in simple terms. So I'm going to come to the surgery center. I got my call. They want me to be there. Let's say if I'm the first patient at 5:30. When would I be in the OR from the time that I got into the surgery center?
So if the patient is first on the list for that day, that would be 7:30. 7:30 is the operating room time. And that's why they have to be at the surgery center at 5:30, because they will be asked to come 2 hours before so that they can go the necessary preparation in the prep and hold area, which is the area where the patients will have the preparation before they go to the operating room. An important fact here to really emphasize is that patients, because they will have anesthesia, they cannot drive home by themselves, right? So it is very important that people are driven to the surgery center by a loved one or by a friend, and then that same person or others would be also responsible for picking them up. So it's very important for people to understand that, although very often, in fact, the vast majority of time in our bariatric center, this is same day procedure, it doesn't mean that they can drive in and drive out themselves, right? It's important that
okay if they don't love each other, though, right? So
that's right. somebody that they have, that they can trust will bring them to the surgery center and will be responsible for picking them up. So that is important. So they come to the surgery center, as you said. Usually it's about 2 hours prior to their allotted time for surgery, and they will be registered at our in our lobby, and then they will be going to, with the nurses, to the preparation area, where they will be changing into a gown, and that preparation will start really with a number of questions asked by the nurse to them, but also by other people. And they may find that these questions are repetitive, right? That there will be a number of people that will come and ask them same questions. When was the last time you had anything to eat or drink, for instance, or what medications have you taken? And patients may think this is redundant, right? But it's really part of our safety process. And redundancy is very important in medicine, right? You have to have different layers of safety so that different people will come from different angles to ask the same questions to confirm that the facts stated are really the fact, right? This is important for safety reasons. Very often patients will find it strange that their surgeon will ask them, oh, what surgery are you having today? Well, the surgeon is asking that not because the surgeon does not know, but because the surgeon wants to confirm, as part of the safety process, from the mouth of the patient, that they are understanding what surgery they are having. And this is part of the informed consent process as well, right? Patients need to understand clearly what procedure they're having, what are the indications for that procedure, what are the potential risks, complications, and expected outcome, the commitment that is needed for that expected outcome. All these are part of the informed consent process that will be starting earlier on in their first counter, but it will be repeated through the process until they are also in the preparation area, where this conversation will be rehashed again and will be rehashed by different people. So I don't want patients to be surprised by that. It is a very important part of our safety process.
the operation in the OR is about like 60 to 85 minutes averagely in the OR.
Yeah, absolutely. So that would be right. Yeah. So, for instance, sometimes if it's a revisional procedure, it could take a little bit longer than that. But for most people, that's really the average time that they will be in the operating time, right? So, other processes that will happen in the preparation area for females of childbearing age, there will be a pregnancy test. Again, we don't want patients to be surprised. They could say, well, there is no way I could be pregnant. But again, as part of our safety process, we have to go through that. So they will be asked to give a specimen of urine for that to be checked. And that is important that that is confirmed before they go to the operating room. And intravenous will be started by the nurses, which are very much experienced in doing that because they do that day in and day out. So I don't want patients to be anxious about that. They are in very good hands with our nurses who start the IV. And then at that time, they will be given some medication as well. And these medications are geared towards really warding off certain potential issues, right? One of them, obviously, is we want patients, as you correctly said earlier on, to have the least discomfort as they wake up, right? So pain is sometimes unavoidable with surgery, but it doesn't have to be terrible pain. It doesn't have to be unbearable pain. And why is that, Kemal? Well, first of all, it's just part of our empathetic and compassionate nature to make sure that our patients don't have pain, right? We are nice. We don't want them to be suffering. But there are also very important reasons, and that is we know very well, for instance, that patients recover better if the pain is well controlled, that patients will have less complications overall if the pain is well controlled. And that is having really good control of pain has always been a challenge of surgeons. And I think in this day and age, I'm actually extremely happy to be practicing at a time in which we are truly controlling pain after surgery, so that, I see patients waking up from anesthesia comfortable, smiling very often, Kamal, which is something I never saw when I was starting to train, 30 years ago. I always saw patients really frowning as they woke up because of the pain that they would feel. But we really have both processes in place now that really help us control pain very well. So one of the medications that they will get in the preparation area will be another medication that really changes the modality of pain transmission by our body in a positive way and in a preemptive way, so that will really help them prevent pain. Another preemptive thing that we do, Kamal, is we give them medication, very strong medication that I am very happy to say we only have available at the surgery center, and that is to minimize nausea, right? I remember about 15 years ago, I was at a conference, Kamal, where there was a team of Brazilian surgeons presenting their data after they've done outpatient bariatric surgery, right? And they were reporting that many of the patients could not really go home. They had to admit them to hospital. And because this was an area I had a lot of interest in, I went to the presenter and I asked him, why are you unable to discharge most patients? And he said the number one cause was nausea and vomiting.
Yeah. Yeah.
Now, you've been in our surgery center many times, Kamal, when you saw patients recovering. How many times have you seen a patient retching because of nausea or sickness? None.
Yeah,
Right?
I haven't seen any.
You don't. So we have excellent ways of controlling nausea. So we don't give the medication when the nausea happens. Of course, you do at the time as well, but it is much better if you give the medication ahead of time, and a strong one at that will really ward off nausea and vomiting. So that's one of the important reasons we are able to send patients home the same day, is because we're able to control nausea and vomiting in such a fantastic way.
There's a lot of misconception around recovery and actually surgery itself. And I believe we were able to change that misconception, at least for those who are experiencing that directly from us, and our team who's witnessing this one-on-one. So, including myself, when we until 2018, we were doing these cases only in the hospital. So I was not able to see none of the patients, in fact, because I wasn't able to go to the hospital. But then when it started at the American Surgery Center, then I was able to go in and out of the certain cases and kind of better understand what was happening. And in the beginning, I remember us keeping patients overnight, and the discussion that we have where patients actually get better, how they heal better, and what's the best setting for them. If clinically, if everything is in the right settings, then their home is the best place. That you actually explained that to me. And that's what we are trying to get our patients to do in the recovery. So I remember, again, our average recovery used to be 8 to 10 hours. Right now it's averaging 6 hours. In some cases, it's less than 6. That's why I'm saying it's averaging. So, and that's mind-blowing in a way that I still see when things needs to be done in the hospital setting, they have to stay overnight.
That's right.
And then understanding that that's not because they're just in a more severe condition. It's just because that's how they do it.
Mm-hmm.
And that's what the facility is able to provide. So, and I'm glad that we were able to make this more pleasant. And earlier, when you were explaining how we prep the patients and the experience itself, I always think about my dentist. So, Erin Radio, she's one of the greatest. There's no pain associated with her. None of my visits, I have any pain. So if I have any trouble, then I know that I can go there, and then I know that I'm not going to be hurt. So mentally, that has a huge impact on my experience there. Again, like it's almost 15, 16 years I go to her, and I have a lot of work done in my mouth, and zero pain. So that, when we translate that into our surgical setting, well, of course, our patients are not going to go through these surgeries so many times, but when they do, how can we actually help the recovery the most is there are different things that we are able to do, which we are doing, which you explained, and I'm glad that we are able to be part of that happy transition and recovery for those patients. So, Dr. Gao, in the last 2 years, it's about 800 cases we have done in the surgery center. I remember only 2 cases where they had to stay over, and that was not clinical reasons. I don't know if you remember any.
Yeah, that's it. That's it. Essentially, it's it's just has to do with the home situation, transport situation. Clearly, it is very important for our patients to know that if we need them to stay overnight for whatever reason, we do have the capability of doing that. We have the staff, we have the facility to do it safely and very comfortably. There's no question about it. But as you said earlier on, the best place for people to be whenever it's safe to do so is at home, where they can recover well. So, and that's what we've been able to do. To add a little bit to the issue of pain control after surgery, as I said earlier on, one of the greatest challenges for surgeons throughout, decades has been pain control, right? To be able to do that. And surgeons have always been able to do really better surgery and great outcomes when they are able to control discomfort, right? Well, in the past, we were controlling pain, but this was at the cost of many, many other potential issues, right? We used to give medications that were very strong, narcotic medications that really, yes, controlled pain, but they slowed down recovery and they created potential complications as well, right? So we used to give even something called patient-controlled anesthesia, or PCA, with very strong pain medication, and something called Dilaudid, really, which is really a cousin of heroin. Kemal, it's a very, very strong pain medication. And, patients, yes, were able to control pain, but they were asleep most of the time. So they wouldn't be able to get up and walk. So it made them really sluggish, right? Their mind was not very clear. And also their digestive system became very lazy. So with all that, yes, you're controlling pain, but you're adding all these other complications of not being able to get the patient up and walking. Well, if you're not able to do that, then the risk of blood clots, the risk of pneumonia, all those will add up, right? So we were able, actually, in our setup that we have right now at the American Surgery Center, to use almost none of those medications. That's an incredible achievement. And that's how it's because we have alternative strategies for controlling pain, including the ones that we use in the operating room, where we apply numbing medicine strategically throughout the abdomen, where we know the nerves are, where we know where they are. And we apply the numbing medicine with quantities that can safely be administered to that patient, so that when patients wake up, they don't even feel the incisions themselves. And this goes on for several hours. And one of the things that I have learned throughout the years, Kemal, is that the perception of pain has to do on how you perceive it at the beginning, very much, right? So if, as you wake up from that unconscious anesthesia state, the first thing you feel is pain, that will color your experience throughout your recovery. You will dread the potential for pain, right? But on the other hand, if as you wake up, you don't experience that pain, and then the first few hours also you don't, even if you have some discomfort later, you're able to control it much better, even with milder pain medication. So all these strategies really have allowed us to get patients to safely go through without experiencing really too much discomfort, which would really slow down their recovery. One of the things we want our patients to do, even within a couple of hours of the surgery, Kemal, is to get up and walk. And the reason we want that is because if they walk, they will really minimize complications like blood clots, like pneumonia, right? But also the fact that the body is in a vertical and walking position switches the mindset into a recovery kind of mindset, as opposed to staying in bed and assuming that sick role, right? When you're in bed and everybody's looking down on you, you're covered by this blanket, you have the monitors, it's very easy to assume that sickness role psychologically, right? And that really slows down your recovery. On the other hand, if you are able to get up and walk, go to the bathroom by yourself, your mindset is already towards recovery. And that's why we're able to enhance that as well. So not only you minimize complication, but you enhance recovery by getting patients to walk early after surgery.
Well, a lot of things are here, right?
Absolutely. Absolutely.
So now we finished the recovery, and now I'm ready to go home. So one of our
Can I add one more thing to that, Kemal? So one of the issues that I was talking about is the prevention of blood clots, right? Blood clots is one of the potential complications that can happen after this surgery, alongside with bleeding, alongside with infection. These are potentially serious, even potentially life-threatening complications, as we explain that to our patients throughout the preparation process, right? So it is impossible to have a situation where there are zero potential for complications. The key is, how do you minimize them? How do you bring the frequency of these complications to a near zero level, right? And that is with prevention, right? If you focus on prevention, you can really achieve a lot. And we really focus on prevention when it comes to complications, and we're able to keep the rate of complications to an extremely low level to make these surgeries comparable in their safety profile to much smaller procedures like gallbladder surgery or hernia surgery. And one of the ways in which, for instance, we minimize the occurrence of blood clots is to give patients blood thinning medication before, right? So one of the medications that they will have in a form of an injection in the preparation area before their surgery, typically an hour and a half to 2 hours before, is this medication, which is a cousin of heparin, low molecular heparin, and we administer that. And that, yes, it does increase the risk of bleeding, but it protects patients very well against blood clots. The other thing that we will do is that as they are about to go asleep, when they are on the operating table, their nurse will tell them, and now I'm going to put some special boots around your legs, right? These are special boots that will actually help pump the veins in the calves, in the legs of the patients. And that by itself is also another additional measure to minimize the risk of blood clots. And obviously, the third and equally important method is to get the patients to walk early after surgery and to continue walking when they go home as well. So the default position when they are home will be walking, right? Yes, they go to bed when they have to sleep. Yes, they go to bed when they need to rest. But they cannot say, oh, I'm going to stay in bed because I had surgery. That's a big no-no. We want them every half hour, every hour, we want them to get up and walk. And that is critically important to minimize the risk of blood clots.
So from the complications, the most crucial time for us is the first hour after the surgery in the recovery room, right? So this first 2 hours, and then once we are over that, so we are kind of in a safe zone almost. Now, I think concerns that I hear from patients when they go home, they have someone who's taking care of them. Even if they don't love them, they still take care of them, right? So what's the, how much do they need to rely on someone to be there with them, especially in the first 24 and 48 hours?
So that's a great point. So let's go back first to that early hours after the surgery, right? Typically, as you said, we keep our patients 6 hours or so in our recovery area, right? The first couple of hours are very critical for us to really watch them very, very closely, because that is the time when one of the potential complications like bleeding can occur, obviously. And we need to monitor them for us to be able to see if that is happening. So despite all the measures that we take to minimize complications, they can happen. So it's not really a question of bringing the complication rate to zero, because that's not possible. It is being able to take care of the complications in a timely fashion, right? Which is very, very important. So we have a setup also of monitoring the patients. So as you correctly said, in that first couple of hours, the patients will be monitored much more intensely compared to the following 4 hours when they are with us. Now, when they go home, we ask them to have somebody around with them, not necessarily because they will be physically dependent on that person, right? We don't want them to be sitting on the chair and tell that person, oh, bring in me water, or do this for me. No, we want them to be independent. You want some water, you get up from your chair and you should be able to get that water. For most people, that should be possible. Obviously, there may be some patients who, for a number of reasons related to disability, might need more help. And those patients may not be necessarily the best candidates for outpatient surgery. But for those who are able to go home and are able to take care of themselves in a normal situation, they should continue to do so, right? But obviously, we do want them, somebody to monitor them in case they have certain symptoms that require them to call us. Now, what are those symptoms? Well, first of all, the general rule that we tell our patients is that if you don't feel well, if you continue to progress, let us know, right? So today should be better than yesterday. And then tomorrow should be better than today. So there should be a progression in how they feel as they are recovering, right? Besides that, if they have severe abdominal pain, if they have fever, if they have nausea, vomiting, or any other question for that matter, we want them to have a very low threshold to call us. And of course, if they feel that there is a life-threatening issue, we want them to promptly call 911 and get some help that way, right? But by and large, patients should be able to take care of themselves, soon after they go home. But having somebody with them really is a very, very important and a good idea, for at least for that first 24 hours when they are at home. And we try to emphasize this, obviously.
And then as soon as a patient goes home, are they able to resume their medications that they were given?
Absolutely. So this is an important issue that has to be individually tailored, essentially, right? Because all patients will have different needs and different medications. So there will be some medications that they have to forego, right? Hold off. And there will be some medication that may be added, after the surgery, or there may be some medications that they were taking before that must be continued afterwards as well. And this will be clarified to them afterwards. Now, there are certain medications that are added after surgery, Kemal. Typically, it is vitamins, for instance, if they were not taking any. It may be calcium, it may be vitamin D. In addition to that, there are two medications that we routinely provide patients. One is an anti-acid medication that we like patients to have for about 6 months after surgery. Another medication for those patients who still have their gallbladder, in other words, who didn't have gallbladder surgery in the past. We give them a medication to minimize the risk of gallstones as they are losing weight, right? These medications should be taken after surgery, but they are not urgent, right? So we don't want them to just worry about taking those medications instead of focusing on hydration. So if taking those medications will give them a sense of gagging, we don't want them to start them, the next day. They can wait 5 days, they can wait, a week before they can start them, right? On the other hand, there is another medication that they have to critically take if they have been prescribed, and that is a blood thinning medication, right? The same blood thinning medication that we have administered to all patients before surgery will actually be administered to some patients for a period of 30 days after the surgery. And these patients will have what we call an extended protection against blood clots because they have, for different reasons, a high risk for blood clot. And this could be patients who have a body mass index greater than 50, for instance. They could be patients who are not as mobile very much for a number of reasons. They could be patients who have a history of blood clots in the past, or patients who have a strong family history of blood clots. So those patients will be given a prescription of medications which are taken as an injection typically. They will start that the first day when they go home, essentially. So the first day, the 0 day will be the day of their surgery, and we are giving them that blood thinning medication. The first day will be the next day, essentially, when they are home. Well, they must start that medication if it has been prescribed by them.
And I think that what's important is for those patients who may be in those conditions, our care managers, our nurses, they're in touch with them, and we prep the patients way ahead of the game anyway, but these are not like some last minute discoveries. We already know what patients are going through because of the screening process that we have. It's extremely clear for everyone so that we will be communicating these way ahead of the surgery. Now, Dr. Irgau, I think the other common issue question is after we go home, our dietary guidelines, what can we eat and what can we not eat and for how long?
Absolutely. So all our patients, regardless of the type of bariatric surgery they have, they will be on what we call clear liquid diet for the first 2 days, right? For the first 48 hours. Now, clear liquids means obviously no food. It's just going to be liquid, but it's also liquids that are transparent. So one way for us to explain that to them is to say, if you can hold a glass that has the liquid that you're about to drink and you can see through it, that's a clear liquid, so you can have it, right? And then after the second day, after that first 48 hours, they will start what's called a full liquid diet. Now, this would be liquids of any thickness, right? And that will include different types of soups, obviously. And they take that for the first 2 weeks. So they are really dietary counseling really is geared towards them having liquids in the first few days after they go home. Obviously, they cannot eat anything. It is critically important that they adhere to this, right? I remember stories, when we were first starting bariatric surgery and going to conferences of patients driving, from the hospital to the first McDonald's to have something to eat. And obviously that was dangerous because here you have a tiny little stomach that is trying to heal and it's very, very stiff as well. And you fill it with these things that require a lot of volume, and that really can disrupt the wound in the stomach and create, obviously major complications. So when we say liquids, we mean it, and patients absolutely must adhere to this guideline. It is critically important. Now, the good thing is, Kemal, is that after they leave our surgery center, after they leave our bariatric center, hunger will not be an issue, at least at the beginning, right? So that should not be an issue at all, right? So the liquid diet is way better tolerated after surgery than it is before surgery, obviously, for this very reason. One issue I would like to mention, Kemal, which is very important for us, is that patients who have sleep apnea and they are on a CPAP machine, it is critically important that they continue to use their CPAP machine when they go home after the surgery, right? And the reason for that is because there could be still lingering effects of anesthesia, and we don't want them to be in any way sedated when they go to sleep with the diagnosis of sleep apnea. So if they have a CPAP machine, the reason we insist that they use it before surgery is because we want them to be practiced as using it so that they can continue using it as they are recovering from the surgery as well.
They can react to the alert that's coming from their body.
Absolutely, absolutely, absolutely. It is important, obviously, that they avoid any type of sedatives. We do not send them home on sedatives. They should not be taking any sedatives if they had them home. They should not take any pain medications beside the ones we prescribe them. So if their loved one tells them, hey, I have some leftover Percocet from people, would you like it? They would say, absolutely not. So all the medications that they should take should be known to us, should be prescribed by us. This is critically important for safe recovery, obviously.
And finally, Dr. Irgau, if we can cover the hydration, how much water they can drink and how they should be drinking, that's kind of another really important issue.
Absolutely, absolutely. Very, very important issue. Thank you for reminding me. So essentially, patients will be on a liquid diet, but they will discover very quickly, even if they've forgotten what we've told them before surgery, is that they cannot take a big gulp at once, right? Because regardless of whether they've had the sleep or whether they've had gastric bypass, their stomach is very small right now, right? So If they cannot take a big gulp at once, it must mean that they cannot afford to wait until they are thirsty, right? They have to prevent thirst. And the best strategy for this is to take sips of the liquids continuously. And what I tell patients is that if you are not asleep, if you are not talking, you are sipping water, right? And if they do that, they can actually get a lot of hydration done throughout time, right? And the example I provide to patients is, there are two ways to fill a bucket with water when you have it under the tap, right? You can either open the tap, and let the water go and it will fill up, or you can let the bucket there and let it drip, right? And given enough time, that bucket will fill up. So that's what we want them to do. We want them to really frequently and proactively take as much fluids as possible. And they will need more water than they think they will, right? And the reason for that is because their body's need for water has not changed. And yet, because they are not eating, they're missing a big proportion of water that they would have normally gotten from their food. That is not happening, right? So they have to make up for that.
Mhm.
Of that, they're not drinking big gulps, so they have to make up for that as well. So hydration is an important issue. And patients often ask me, how do I know whether I am getting enough water or I'm hydrated? Well, you can, if in extreme cases, you can feel it yourself, right? When you're dry, your mouth will be dry. We don't want to get to those levels, but a good way to gauge that would be to look at the color of their urine, right? So if the urine looks more like water, right, they are getting good hydration. If the urine looks more like tea and it's dark and concentrated, it means that their kidneys are working overtime to try to preserve water, right? And everything that's coming out is concentrated, right? It means they don't have enough hydration. So that's a good way for them to gauge whether they're getting enough hydration or not.
And that's also true for, it doesn't have to be just post-surgery, but for anyone.
Yeah, absolutely.
Urine is too dark, that means you're not drinking enough water.
That's right.
Now we wanted to kind of keep the topic around the surgery day, the day before, the day after. So we'll probably just finish it here for today, Dr. Erkan, for what needs to happen for the week or the 2 weeks and 3 weeks. So one really important part is there is a follow-up appointment. Usually it's like 7 to 10 days. Do not miss that. Do not miss your first month. Any of your follow-ups, don't miss them, because they are the most important part of the journey. So it's great that you are gonna lose a lot of weight, but making necessary adjustments and make it long-term, then you need all those follow-ups and everyone else's help. And we want to make sure that there is no complication. There's nothing that we can actually prevent that should be happening. So, and we have every tools in place to do that. So we want to make sure you stay in communication with us, with our offices. Use our patient portal. Phone calls are not the best way to reach us. On our website, you can actually get through us in several different ways, but the patient portal is the fastest one. And we hope that everyone who's going through the surgery would have a very decent experience, as just like any of our other patients, with 98.2% satisfaction rate. I know patients are going to be happy. Join our support group on Facebook or our monthly Zoom support meetings. You can register through our website at CHRIAS, and those are the best way to kind of get you ready for the future journey. Dr. Erkan, thank you so much for joining me today, and we'll be back next week with another topic.
Thank you. Bye-bye, Kemal.
Thank you.